Basically, awake craniotomy, it's that we keep you pretty much conscious and awake during the critical part of the procedure. Basically, there's no general anesthesia, you won't have a breathing tube, and I'll be able to map your brain directly during the procedure. So basically, it's sort of a customizing the procedure for your operation. In simple terms, it's like if your brain is a conscious organ, so you don't want to put it down under general anesthesia when you're doing surgery or procedures on it. So, so that's the whole idea. And there's always this concept of the brain plasticity, the difference between everybody's function location on the brain as opposed to the anatomy. So it's like when you do the MRIs and stuff, and so you see the anatomy and you know where things are. But again, each patient's function may be different in relation to anatomy and what we know. So basically, any few millimeters difference in the location of the function of that part of your brain, it's important to preserve that function during the operation. So during the procedure, for example, if you want it's a tumor or any other lesions, you'll be under sort of IV sedation and some local sedation anesthesia at the beginning of the procedure. But then while the brain is exposed, then we will start to let you wake up and participate during the critical part of the procedure, which is basically, so we'll ask you questions. There is a neuropsychologist in the room. We'll ask you questions. We'll show you pictures. We'll ask you to perform some tasks, and at the same time, I'll be mapping the brain in order to find a part of the brain that functionally it's not eloquent or important for you, in order to approach the lesion and try to take it out as safe as possible. And that will allow me also to sort of go by what we call functional boundaries as opposed to just anatomical boundaries or what we see just on the MRI. So these are all new concepts that we are learning. The more we do this, the more we sort of realize that the function and the anatomy does not match always 100%. So if I can save your function, it's extremely important. So no surprises after the operation. Basically, there's no breathing tube to take out afterwards, and we know your function during the procedure anyway. So post-operation, after surgery, we'll be able to remove most of the lesion or tumor, for that matter, and then you will be with all the functions preserved. So and lots of time patients, they can go home, the first day or second day after the procedure. So it's minimizing the risk of the operation, and at the same time sort of designing the procedure with your functionalities. And this collaboration between the anesthesiologist and the surgeon, and of course the patient is a team of people in the operating room, including the neuropsychologist, specialist who is testing the patient directly, and the electrophysiology monitoring people, and the anesthesiologist. So it's a very